Good evening, Doxy. We are the last group, and we're here to report about the outpatient management of hypertension. Our patient is a 56 years old hypertensive man is being evaluated as a new patient. His blood pressure are in a range of 170 over 95 millimeters mercury, and with a fundoscopic examination reveals hypertensive retinopathy. The point of maximal impulse is placed laterally, suggesting cardiomegaly. A fourth heart sound is consistent with a non-compliant ventricle, and in addition of this, he has a multiple cardiovascular risk factors including his age, obesity, and smoking. Our next step is to provide a laboratory evaluation to evaluate renal functions such as electrolytes, creatinine, and urinalysis. Evaluation of other cardiovascular risk factors such as serum, glucose, and lipid profile, and a baseline of ECG assessment for a target organ damage. Our next step is to start a patient on a 2-drug antihypertensive regimen that includes thiazide and a diuretic. Recommended lifestyle change is most important, and a cessation of the use of tobacco. For the definition of terms, essential hypertension, known as idiopathic or primary hypertension, it has no known cause yet, and it comprises approximately 80 to 95 cases of hypertension. Lifestyle modification is a cornerstone in the treatment of hypertension, consisting of a regular aerobic activity, weight loss, decreased salt intake, and decreased intake of fat, especially saturated fat in the diet. Alcohol consumption should be moderate with no more than 2 glasses of wine per day. For men, and it is regulated for 1 glass per day, and for a woman, it is regulated 2 glasses per day. Hypertension is a blood pressure of 120 to 139 over 80 to 89 millimeters mercury. We say it is stage 1 hypertension if the blood pressure reaches up to 140 to 159 over 90 or to 99 millimeters mercury. While your stage 2 hypertension is a blood pressure of more than 160 over 100 millimeters mercury. Secondary hypertension is an elevated arterial blood pressure with known underlying cause such as renal artery stenosis or primary aldosteronism. Prevalence is approximately 5% to 20% of all cases of hypertension. For the next reporter, I'll give you Sherwin Victa.
Go. Okay, good evening. For clinical approach, diagnosis made by initial evaluation and management. And hypertension must be staged to guide the intensity of medical intervention. Measuring blood pressure on 2 or more occasions may evaluate the underlying causes of hypertension to consider. Then, essential or idiopathic hypertension is the most common form of hypertension, comprising 80% to 95% of cases. But approximately 5% to 20% of cases of hypertension are caused by secondary causes. So, the example of secondary causes of hypertension is renal disease, such as parenchymal, like glomerulonephritis, physical kidney disease, renal tumor. For endocrine, primary aldosterone, Cushing syndrome, hyperthyroidism. So for miscellaneous like obstruction, sleep apnea, coarctation of aorta, hypercalcemia, medications such as glucocorticoid and high estrogen NSAIDs. Then next, a clinician must be aware of the clinical and laboratory manifestation of the process. Secondary cause of hypertension are thus need more extensive testing, especially for patients have any of the following clinical features. One is age of onset before 25 years old or after 55 years. Then presenting with malignant hypertension. Next is refractory hypertension, reassuring 3 or more anti-hypertensive medication. Next, the selective causes of secondary hypertension. The most common cause of secondary hypertension is renal disease. Renal artery stenosis is caused by atherosclerotic disease with hemodynamically significant blockage of the renal artery in older patient, or by fibromuscular dysplasia in younger adult. The clinician must have a high index of suspicion. Checking of potassium level may be low or borderline low in patient with renal artery stenosis caused by secondary hyperaldosteronism. Then other diagnosis tools include magnetic resonance angiography and spiral computed tomography, surgical or angioplastic correction of the vascular occlusion may be considered. Then polycystic kidney disease is inherited as an autosomal dominant trait. The classic clinical triad are the positive family history of polycystic kidney disease, bilateral flank masses, flank pain, and elevated blood pressure and hematuria. Next, polycystic kidney disease is inherited as a dominant trait. Classic clinical findings are positive family history of polycystic kidney disease, bilateral flank masses, flank pain, elevated blood pressure, and hematuria. Then the other cause, for the next reporter, Ladaw.
Yeah. Good evening, Doxy. We are the last group, and we're here to report about the outpatient management of hypertension. Our patient is a 56 years old hypertensive man is being evaluated as a new patient. His blood pressure are in a range of 170/95 millimeters mercury, and with a fundoscopic examination reveals hypertensive retinopathy. The point of maximal impulse is placed laterally, suggesting cardiomegaly. A fourth heart sound is consistent with a thickened non-compliant ventricle, and in addition of this, he has a multiple cardiovascular risk factors including his age, obesity, and smoking. Our next step is to provide a laboratory evaluation to evaluate renal functions such as electrolytes, creatinine, and urinalysis. Evaluation of other cardiovascular risk factors such as serum, glucose, and lipid profile, and a baseline of ECG assessment for a target organ damage. Our next step is to start a patient on a 2-drug antihypertensive regimen that includes thiazide and a diuretic. Recommended lifestyle change is most important, and a cessation of the use of tobacco. For the definition of terms, essential hypertension, known as idiopathic or primary hypertension, it has no known cause yet, and it comprises approximately 80 to 95 cases of hypertension. Lifestyle modification is a cornerstone in the treatment of hypertension, consisting of a regular aerobic activity, weight loss, decreased salt intake, and decreased intake of fat, especially saturated fat in the diet. Alcohol consumption should be moderate, with no more than 2 glasses of wine per day. For men, and it is regulated for 1 glass per day, and for a woman, it is regulated 2 glasses per day. Hypertension is a blood pressure of 120 to 139/80 to 89 millimeters mercury. We say it is stage 1 hypertension if the blood pressure reaches up to 140 to 159/90 or to 99 millimeters mercury. While your stage 2 hypertension is a blood pressure of more than 160 over 100 millimeters mercury. Secondary hypertension is an elevated arterial blood pressure with known underlying cause such as renal artery stenosis or primary aldosteronism. Prevalence is approximately 5% to 20% of all cases of hypertension. For the next reporter, I'll give you Sherwin Victa.
Okay, good evening. For clinical approach, diagnosis made by initial evaluation and management. Then, hypertension must be staged to guide the intensity of medical intervention. Measuring blood pressure on 2 or more occasions may evaluate the underlying causes of hypertension to consider. Then, essential or idiopathic hypertension is the most common form of hypertension, comprising 80% to 95% of cases. But approximately 5% to 20% of cases of hypertension are caused by secondary causes. So, the example of secondary causes of hypertension is renal disease, such as parenchymal, like glomerulonephritis, physical kidney disease, renal tumor. For endocrine, primary aldosterone, Cushing syndrome, hyperthyroidism. So for miscellaneous like obstruction, sleep apnea, coarctation of aorta, hypercalcemia, medications such as glucocorticoids and high estrogen NSAIDs. Then next, a clinician must be aware of the clinical and laboratory manifestation of the process. Secondary cause of hypertension are thus need more extensive testing, especially for patients have any of the following clinical features. One is age of onset before 25 years old or after 55 years. Then presenting with malignant hypertension. Next is refractory hypertension, reassuring 3 or more anti-hypertensive medication. Next, the selective causes of secondary hypertension. The most common cause of secondary hypertension is renal disease. Renal artery stenosis is caused by atherosclerotic disease with hemodynamically significant blockage of the renal artery in older patient, or by fibromuscular dysplasia in younger adult. The clinician must have a high index of suspicion. Checking of potassium level may be low or borderline low in patient with renal artery stenosis caused by secondary hyperaldosteronism. Then other diagnosis tools include magnetic resonance angiography and spiral computed tomography, surgical or angioplastic correction of the vascular occlusion may be considered. Then polycystic kidney disease is inherited as an autosomal dominant trait. The classic clinical triad are the positive family history of polycystic kidney disease, bilateral flank masses, flank pain, and elevated blood pressure and hematuria. Next, polycystic kidney disease is inherited as a dominant trait. Classic clinical findings are positive family history of polycystic kidney disease, bilateral flank masses, flank pain, elevated blood pressure, and hematuria. Then the other cause, for the next reporter, Ladaw.
So these are the other causes of secondary hypertension. Coarctation of aorta can cause claudication, cold extremities, and diminished or absent femoral pulses as a result of a decreased blood pressure in the lower extremities. Second, carcinoid tumors arise from the enterochromaffin cells located in the gastrointestinal tract and in the lungs. Clinical manifestation includes cutaneous flushing, headache, diarrhea, and bronchial constriction with wheezing and often hypertension. Pheochromocytoma is a catecholamineralizing tumor that typically produces hypertension. Clinical manifestation includes headaches, palpitation, diaphoresis, and chest pain. Other causes of secondary hypertension includes primary hyperaldosteronism, which typically will cause hypertension and hypokalemia. Anabolic steroids, sympathomimetic drugs, tricyclic antidepressants, oral contraceptives, non-steroidal anti-inflammatory drug agents, and illicit drugs such as cocaine, as well as illicit ones such as caffeine and alcohol are included in the possible secondary causes of hypertension. Obstructive sleep apnea is another fairly common cause of hypertension. Most patients, this is a result of reduced airway size that is congenital or perhaps complicated by obesity. Next is hyperthyroidism may also cause hypertension. The patient will have a widened pulse pressure with increased systolic blood pressure and decreased diastolic blood pressure. Next is the glucocorticoid excess states, including Cushing syndrome and iatrogenic state, usually present with thinning of the extremities and truncal obesity. An excess of corticosteroid can cause secondary hypertension because many glucocorticoids hormones have mineralocorticoid activity. So these are the partial listing of antihypertensive agents. So the category is diuretic, agent is hydrochlorothiazide, and the side effect is hypokalemia, hyponatremia, carbohydrate intolerance, hyperuricemia, hyperlipidemia. The contraindication of this is diabetes mellitus, gout, and hypokalemia. Next is anti-adrenergic. Example of this agent is clonidine. Its mechanism of action is stimulation of alpha-2 vasomotor center of the brain, and the side effect is rebound hypertension. The contraindication of this drug is history of medication or non-compliance. The next one is vasodilator. Example of this drug is hydralazine. The mechanism of action of hydralazine is arterial vasodilation, produces reflex tachycardia, and the side effect is headache, tachycardia, angina, lupus-like syndrome. And the contraindication is severe coronary artery disease. The next category is the ACE inhibitor. Example of this drug is captopril. The mechanism of action is it inhibits conversion of angiotensin 1 to angiotensin 2. It is a powerful vasoconstrictor. The side effect of this drug is orthostatic hypotension, cough, angioedema, hyperkalemia, or acute renal failure. The contraindication is renal failure itself, bilateral and artery stenosis, or pregnancy. The next category of this antihypertensive agent is angiotensin receptor antagonist. Example of this drug is losartan. Its mechanism of action is competitive inhibition of angiotensin 2 receptor, and the side effect is similar to ACE inhibitors but no cough or angioedema. The contraindication is pregnancy, bilateral renal artery stenosis. And the next one is calcium channel antagonist. The example of this drug is amlodipine. The mechanism of action is blockade of L channels, reducing intracellular calcium, and causing vasodilation. The side effect of this drug is edema, and there is no set of contraindication. Next is yun lang. Thank you. So guys, that ends our report. Thank you so much. Good night.